start with angina or angina. And by definition, this is the chest pain secondary to coronary artery narrowing or spasm, but no necrosis. We have three types of angina. One is the stable angina, and this is commonly secondary to atherosclerosis. It means more than 70% occlusion of the coronary artery, and it's characterized by chest pain with a classic distribution. It means retrosternal chest pain, and that's radiated to either to the shoulder or the right or left shoulder or the epigastric region or to the back. We'll go with this after. And associated with depression on ST segment depression on ECG, and usually resolved with the rest or nitrates. And then we have the vasospastic angina or the transmittal angina, which is the angina at rest due to spasm of the coronary artery, and is associated with a transient ST segment elevation. And the risk factor for the vasospastic angina is a tobacco risk, tobacco smoking, hypertension, and hyperlipidemia, may be induced by triptans, by cocaine, by alcohol, and is treated by calcium channel blockers, nitrates, and smoking cessation. Yeah, then we have the unstable angina, and the unstable angina means that the angina that can happen at rest, or the crescendo angina, the angina with increased frequency, or that's recurrent more than once. That it happens at rest or it happened post myocardial infarction. Those are the characteristics of unstable angina. And usually this is caused by thrombosis with incomplete coronary artery occlusion. It might be associated with or without ST segment depression and or T-wave inversion. But with unstable angina, there is no cardiac biomarkers elevation. That's to differentiate it from the non-ST segment elevation myocardial infarction. And as I said, this is unstable angina characterized by chest pain at rest. These types of angina is we will go after with the differentiation with the other types of chest pain or other causes of chest pain. And here, as you can see, the characteristics of the different types of chest pain with the ischemic the ischemic pain and the other types of or the different types of angina. So stable angina, you will have chest pain between 2 to 10 minutes. In acute coronary syndrome, you have the chest pain more than 10 minutes to 30 minutes. And usually the provoking factors or the initiating factors will be physical activities, cold, emotional stress. It can happen after eating. It can happen after sexual intercourse. All those factors are provoking factors for development of the ischemic chest pain. The associated symptoms, usually it's associated with shortness of breath, with nausea, with dizziness, with fatigue. And the location of chest pain here in angina is substernal or retrosternal, and radiated to the neck, to the lower jaw, to the teeth, to the arms, to the shoulders, to the epigastric region. And in attention, that you should pay attention to the any question that shows the pain radiated to the epigastric region, because that might signify an inferior ischemia. And the quality of pain, usually squeezing or tightness or heaviness or pressure or burning or aching pain or ill-defined pain. And the general characteristics of ischemic chest pain, usually it's not tender. Any tenderness, or if the patients can point to the site of chest pain, this is actually reject the diagnosis of ischemic chest pain. And not positional, it means it doesn't change it's not decreased or increased by changing the patient's position. And not pleuritic, it means it's not sharp localized pain. the patients can define. And most common cause of non-ischemic chest pain usually is GI pain that can radiate to the chest too. So when you have the approach to patients with chest pain, when you have patients presented with chest pain, the first step, also pay attention to this for any question. The first step in the exam, you start with the simple test and then you proceed to the more complicated test. So if you have a question that asks about what's the next step, so think always as a primary care doctor. So they want you to think as a primary care doctor if the patient's coming with chest pain. So the first step in the emergency after clinical examination will to order an EKG. If you have an EKG, you proceed to the next step. So in the EKG, the ECG, I mean, if you have an ST segment ECG or EKG, the question can be both terms. So if you have an ST segment elevation, so this is the diagnosis of ST segment elevation myocardial infarction. And if the ECG doesn't show ST segment elevation, you look at the cardiac enzymes. If the cardiac enzymes are elevated, this is non-ST segment elevation myocardial infarction. If the cardiac enzymes are not elevated, this is unstable angina. So in general, to diagnose myocardial infarction, you should have 2 criteria out of 3. When you have chest pain, ECG changes, and biomarkers. If you have 2 out of 3, that's the diagnosis of myocardial infarction. So if the ECG shows ST segment elevation, this is ST segment elevation myocardial infarction. And if there is no ST segment elevation, this is non-ST segment elevation myocardial infarction.